All right, we'll go ahead and get started. Hi, everybody. My name is Peter Chin. I'm a fourth year med student at Case Western. Welcome to Patho-Mnemonic. This is an NBME shelf exam and Step 2 CK content review series. This was inspired by content review series and YouTube videos and podcasts that I found during my rotations and during dedicated for Step 2 that I found super helpful. And so now that I'm on the other side of everything, I kind of wanted to try my own hand at making this kind of a resource with the hopes that it's something that's more accessible or at least complementary to the kind of stuff that you guys are using to learn and practice material. This is a pilot episode, so I'm just going to cover a little bit of content. Um, so if you are watching this and you have feedback on things that can be improved, things that I should keep doing in the future, please let me know. I would really appreciate your feedback. Okay, so my bias is showing a little bit. I'm interested in Pete's cardiology, but cardiology in general. So I figured I would start with something that I'm comfortable with. So in this episode, I'm going to go over the cardiac conduction system. We'll go over some arrhythmias and the management of those arrhythmias. So here I have a diagram, not anatomically accurate at all, of the cardiac conduction system. So the beat is first generated in the SA node, and then that depolarizes the atria, goes to the AV node, and then there's like a little bit of a pause or a delay. And then from there, the electrical impulse goes through the bundle of His, and then it splits to the left and right bundle branches, and then it goes to the Purkinje fibers to depolarize the ventricles. So here's like a superposition of the leads of an EKG, or at least some of them, like one, two, three, AVR, AVL, AVF. You're not going to need to know the specific positions of these leads per se, but it might be helpful to have this in the back of your mind when you're trying to orient yourself when it comes to interpreting EKGs, or at least like initially understanding what each EKG lead is showing you. And then here are the V1 through V6 leads in an EKG. Notably, like V1, V2, or just like from V1 through V6, that progresses from right to left. And so you can kind of see that depicted here. V3 kind of like represents the isoelectric point or the interventricular septum. Okay, so here's a normal EKG. And then on the EKG, I've just kind of circled some things that I pay attention to when I'm going through an EKG. Your approach to interpreting EKGs may be different from mine, and that's not to say that yours is right, mine's wrong, or mine's right and yours is wrong. But if you have like no idea how to approach an EKG, maybe my process will help you initially, and then you might develop your own thing. Um, so I'll say first, like when I'm looking at an EKG, the first thing that I look at is actually the rhythm strip, because that gives me like the best holistic view of what the heart is doing from an electrical standpoint. And then after I just look generally at the rhythm strip, then I look at the V1 through V6. And in that, like sometimes I'll look at the QRS complexes in particular, and I'll look to see if there's like appropriate axis progression, which basically means that you would want to see a largely negative QRS in V1, and then it progresses from negative to becoming more positive until it's positive in V6. And if you look back at this diagram here, and you think about the QRS complexes, a negative, like that little initial peak, that upward deflection in V1 followed by the downward deflection afterwards, that kind of represents the right ventricular depolarization, which is that little upstroke, and then the left ventricular depolarization away from V1, which is that downward deflection. But that's that's like as detailed as I'll go. Um, and then the same thing for V6, right? Like that right ventricular one is like just a little downstroke, and then the upstroke is the left ventricular depolarization. Um, but in general, like if you are if you put yourself in the perspective of an EKG lead, and you imagine the EKG lead has an eye, um, if you are looking at something like an object and it's getting closer to you, it's going to get bigger. So in this case, like an analogy would be depolarization of myocardium, as it's getting closer to you, it's going to get bigger. And so that'll be like an upward deflection on an EKG. And then an object that's going away gets smaller, follows the same logic or the same logic. And there's a downward deflection. Um, and then we'll do a little bit of mental gymnastics. Two negatives make a positive. So an approaching object that is negative. So instead of depolarization, you have repolarization. So that's like the negative. So if it's approaching and it's negative, then it gets smaller, which is a downward deflection. And then by that logic, an object, a negative object that's going away, two negatives make a positive, and so that gets bigger, which is an upward deflection. Okay, so in this, for these next couple of slides, I'm just going to have some EKGs. Maybe I'll have like um, a vignette about like the symptoms that the patient might be having. But in many cases, if you're presented with an EKG on like a shelf or a step two question, many times you might actually be able to get the right answer just by looking at the EKG. And then after you look at the EKG, then you can kind of say like, okay, I think this is like a differential diagnosis. And then as you're reading through the vignette, you might be like, all right, these features that I'm seeing in the vignette are agreeing with what I'm thinking is going on based on the EKG. Obviously, in real life, like you're going to see the patient first and get a history and do a physical before you get the EKG. But I mean, let's be honest, if you're like flipping to the next question on a shelf or step two, the first thing that you're going to see is an EKG. Um, so yeah, like I said, better to learn with practice. So in this first example, there's someone coming in maybe to the emergency room. They have palpitations. They may or may not have lightheadedness. They may or may, they might have gotten close to passing out, or they may have passed all the way out, um, so on and so forth. And then the EKG is shown here. Um, so at this point, you've probably had a chance to look at this EKG. I'll just get to the answer. This is atrial fibrillation or AFib. So keep this EKG in mind. We're going to come back to some of the specific details when we compare it to another EKG. So if you look at this EKG, they might present with the same symptoms, palpitations. They may or may not have lightheadedness. They may or may not have gotten close to or passed all the way out. And then again, the EKG is shown. In this case, this is atrial flutter. So, like I said, we would come back to these EKGs. One thing that really helped me learn EKGs was um, not only comparing normal to abnormal, but comparing abnormal to abnormal. Because initially, when I was looking at EKGs, I would be like, okay, it could be this or it could be this, both of which are abnormal. And being able to differentiate, like, okay, why is this one, like, why is this diagnosis more in line with this EKG as opposed to this other one? So that's what we're going to do here. Um, so first things first, we're going to start with some causes of AFib. This is pretty high yield, and it's a lot of causes. It could be like left atrial dilation. Um, so someone could have like a long-standing history of mitral stenosis from rheumatic fever, um, or it could be like congestive heart failure. Hyperthyroidism is another cause. Infection, smoking, caffeine, hypertension, so on and so forth. But in general, it's just nice to keep in the back of your mind that AFib is more a manifestation or a symptom of something underlying than it is a primary diagnosis. I mean, obviously, you would still manage the AFib, but if there's an underlying diagnosis, you want to find that and treat it as well. So, with regards to the anatomy of um, AFib versus a flutter, in the case of AFib, the electrical impulse, like this aberrant electrical impulse pulse, courses around the pulmonary vein ostia. And so in a normal heart, the left atrium has four pulmonary vein ostia. So I've diagrammed those here. And if you think about, or if you like imagine an electrical impulse, it like, might course around one and then it'll go to a different one and it'll just kind of like bop all over the place in the left atrium. And then occasionally an electrical impulse will conduct to the ventricles, or the ventricles might generate their own beat. Um, and so that produces an irregular baseline that you can see on the EKG, but it also produces an irregular ventricular rhythm, which again you see on the EKG. In the setting of atrial flutter, the electrical impulse courses around the tricuspid valve. And so since there's only one structure that's the nidus for this aberrant electrical impulse, It's still it produces a more regular atrial rhythm, so to speak, and that shows up as that classic sawtooth pattern on the baseline in an EKG. Um, so you can see like the difference between the like really weird, irregular, like not so much of a pattern in the baseline in afib, but in a flutter you see that regular sawtooth pattern. Um, Management wise, like I said before, you want to determine and treat if there's an underlying cause of AFib. So, like if someone's presenting with weight loss and heat intolerance, and you look at them and they have really bulging eyes and they're tremulous and they're like hot and sweaty, you would want to think hyperthyroidism, and then you would want to get a TSH, a T4, T3, so on. You would want to work that up and manage it accordingly. Um, and then another thing for AFib and aflutter, and then just for any arrhythmia, as we'll see coming up, you want to determine once you've made the diagnosis, you want to determine if they're hemodynamically stable or if they're hemodynamically unstable. Um, my general rule of thumb for determining stability is um, if they seem tachycardic, there's not like a number that I have in my mind per se, but if they seem tachycardic and for me, it's really the blood pressure. If their blood pressure, my cutoff is like 90 over 60. So if they're above 90 over 60, then they're probably stable. But if they're below 90 over 60, then I'm more likely to think that they're hemodynamically unstable, and that changes my management. So if a patient has AFib or aflutter and they're hemodynamically stable, they get beta blockers, verapamil, or diltiazem as pharmacotherapy. Um, if they're unstable, they get cardioversion. And then another thing to keep in the back of your mind when you're thinking about AFib or aflutter is the CHADS-VASc score. And then, like I said, we'll get to the CHADS-VASc in a second, but in the meantime, a quick aside, the same deal is for atrial flutter as it is for atrial fibrillation. Um, so here's the CHADS-VASc score. I'll just list all of them here. Okay. So in order, it's congestive heart failure, hypertension, age greater than 65 years old, diabetes, mellitus, stroke, vascular disease like peripheral artery disease. They get another point if they're older than 75. So in that age category, they get 2 points if they're older than 75. Um, and then if they are of the female sex category. Um, And so based on how many of these boxes you check, that like score determines the management, like a long-term management, not related to the arrhythmia itself. So if they have none of these features, then you don't really need to do anything aside from control the rhythm. Um, but if they have at least 1 point in the CHADS-VASc score, then you want to consider anticoagulation, like a direct oral or direct acting oral anticoagulation or a DOAC like rivaroxaban or any other medication that ends in XA or Xaban. And then like if you think about the wording of it, it's like XA or 10A, and then it bans factor 10A. And that's how, I don't know, that's how I remember it. Um, or warfarin. But remember, if you want to start with warfarin, well, if you want to start someone on warfarin, you have to bridge them with heparin. And then the reason why you want to consider CHADS-VASc in the setting of atrial fibrillation or atrial flutter is because in this state, there's stasis of blood in the atria. And so if you think of Virchow's triad, stasis, hypercoagulability, endothelial dysfunction, stasis is like that's the box that gets checked. And so in that case, someone that has AFib is like meeting criteria for Virchow's triad, or they fit into Virchow's triad. And so stasis in the left atrium can coagulate, and then they risk throwing that coagulation into like the brain or the limbs or to the gut or something like that. And obviously, you don't want that to happen. All right, so we're going to move on to a couple other EKGs. Same deal as last time. I'll show them. We'll get the diagnosis of each, and then we'll compare. So here's this EKG. Again, the patient will present with like palpitations, lightheadedness, maybe syncope. EKG is shown. So if you'll look at you'll look at this EKG. Um, and since I've seen this one before, I know what the answer is. But like I said, we'll go over it. This is supraventricular tachycardia or SVT. Um, Okay, right. We will move on to this EKG. Again, it might have the same symptoms, like palpitations, is like a feeling like their heart is pumping in their chest. They may or may not have lightheadedness. They may or may not have passed out. Same deal as before. EKG is shown. Um, okay, so this is AFib with rapid ventricular response or AFib with RVR. All right, so like last time, here are the rhythm strips for both SVT and AFib with RVR. And this is how I differentiate between them. So if you look at the rhythm strip, SVT has it's a regular tachycardia. And you can see that by looking at the distance between the QRS complexes. Like it's pretty much the same distance between complexes. Whereas if you look at AFib with RVR, it's a tachycardia, but the QRS complexes aren't spaced out the same from each other. Like these two look farther away from each other than like these two, and that kind of applies to the entire rhythm strip. Um, and then, so if you think about why this happens, in the setting of SVT, there's a reentrant loop. And so this kind of gets into the category of AV reentrant tachycardia or AV nodal reentrant tachycardia. Um, and then, like we've seen before with AFib, some of the electrical impulses conduct to the ventricles. Um, or like if there's not enough blood filling the ventricles, then, by that mean there's not, or by that logic, then there's not enough blood leaving the ventricles. And so then there might be um, so that as a consequence, there's like decreased perfusion. And then so that can stimulate the sympathetic nervous system to increase heart rate. And then that's why you get a tachycardia. Um, so if here's our diagram of the cardiac conduction system. Um, so we'll start with SVT. So SVT, like I said, AV reentrant tachycardia or AV nodal reentrant tachycardia. In both cases, there's a regular reentrant loop, which produces a regular tachycardia. So in AV reentrant tachycardia, there's an accessory pathway that um, allows the electrical impulse to return to the atria directly from the ventricles. And so, like the ventricle depolarizes, and then it depolarizes the atria, and then because the atria are depolarized, then it just follows the same pathway and then depolarizes the ventricles again. Or it could go the other way in that the atria depolarize and then it follows the accessory pathway to depolarize the ventricles. So, the arrow could point both ways. In AV nodal reentrant tachycardia, the reentrant loop is just in the AV node. There's like some physiology about like the slow and fast conduction pathway. You can look into that or read about it, but like with regards to shelf or step exams, that's not as important to know. Um, so for AFib, um, that's like the arrows in black. So it's like they're coursing around the pulmonary vein ostia. Some of them are conducting to the ventricles. And like an example, so here on this EKG, I'm pretty sure this like one really weird looking QRS complex is a premature ventricular complex or complex or contraction or whatever, or a PVC, um, which like if you think about the irregular conduction of the heart, it just means because it's like the complex is a little bit wider, so you might think that like this like morphology is consistent with a PVC. But more important is to like look at the irregularity versus the regularity of SVT. Okay, so here's another EKG. No symptoms this time, but that's just because this is just like you either know it or you don't based on the morphology of the EKG. This is Wolff Parkinson White. Um, so here's the diagram of the cardiac conduction system. There is an accessory pathway in Wolff Parkinson White, but unlike in SVT or AV NRT, um, it just bypasses the AV node and then depolarizes the ventricles. So because there's some like pre-excitation of the ventricles before the rest of the electrical impulse makes it to the ventricles through the normal conduction pathway, that's what causes this like slurred upstroke in the QRS complex. Okay, so here's another EKG. Um, again, like this is a recognition of morphology. And then you can, yeah, this is just recognition of EKG morphology. This is AFib with pre-excitation or AFib with Wolff-Parkinson White. We will come back to this EKG. We'll come back to the rhythm strip and compare it to another one, just so you're not like absolutely confused about what to do if you see something like this. Um, so here's the cardiac conduction system, AFib coursing around the pulmonary vein ostia, and then that concept, together with the concept of Wolff-Parkinson White, it bypasses the AV node and then immediately depolarizes the ventricles. And so if you we'll get into more specific detail about this in the coming slides where we compare it to another EKG, but you can kind of see like a little bit of a slurred upstroke on some of these QRS complexes. Um, but you might see this and be tempted to think it's an EKG that looks different. Spoiler alert, it's this one. Um, so you might have thought that the previous EKG was the diagnosis that this EKG is representing, which is VTAC. Um, so we'll go on to the next slide where we just compare. So here's, before we go on to compare it to Wolff-Parkinson White, we'll just reiterate the anatomy of the cardiac conduction system. So in VTAC, the depolarization is just circulating around the ventricles. Um, and the ventricles, like, from a physiologic standpoint, they have those gap junctions that allow for synchronized depolarization of the myocardium. But those gap junctions aren't as specialized as the cardiac conduction system. They're not as good at depolarizing the entire ventricle all in one go. So it takes a little bit longer for the electrical impulse to depolarize the entire ventricle. And so as a result, the QRS complex, if you could call it a QRS complex, it gets wider because it takes more time to depolarize the entire ventricle. Um, and so that's what produces this like regular wide complex tachycardia. Okay, so here's the comparison of the rhythm strips between VTAC and AFib with Wolff-Parkinson White. Um, so again, if you compare the rate and rhythm, well, both are tachycardic, but then you compare the rhythm, VTAC has a regular wide QRS complex tachycardia, and that's what shows up on the EKG. And then if you compare that with AFib with RVR or with pre-excitation, um, it's irregular and it has narrower QRS complexes. And then if you look at some of these QRS complexes, like you can maybe see a little bit of slurred, um, like that slurred upstroke uh, in the QRS complex. Um, Before we talk about this one, I'll just make one more point about the VTAC versus AFib with pre-excitation. The reason why this is relevant, like you've probably rarely ever seen AFib with pre-excitation before, but you might be asked about how the management or how to manage a condition like this. And so the reason why I even brought this up is because the management is different for AFib with pre-excitation in comparison to AFib or AFib with RVR. Okay, so here's another EKG. Um, this one doesn't look too good. This is VFib or ventricular fibrillation. Um, and we will contrast this EKG with this EKG, which is torsade de pointe. So if you're looking at this EKG for VFib and you're like, oh, this looks like it could be torsade de pointe because it like, it's got this undulating pattern and the amplitude changes a little bit. Yeah, I see where you're coming from. But if you look at the baseline is changing, which kind of gives the illusion that there's some oscillation of the actual like rhythm. And there's a little bit of amplitude variability throughout the baseline. But if you look at, like, if you compare this picture to the picture of torsade de pointe, there's like really significant changes in amplitude. And it really looks like that twisting of a streamer, like a party streamer in torsade de pointe. This EKG is pretty straightforward. This is asystole. Okay. So, like I said before, we'll talk about the management of tachyarrhythmias. Um, the first thing that I use in my mind is um, once I figure, the first thing I do is I figure out the type of tachyarrhythmia. And then once I figure out the type of the tachyarrhythmia, then I determine, okay, are they stable? Like that, are they above that magic 90 over 60 blood pressure? Or are they unstable? And then based on that picture, then that tells me how to manage them going forward. So for SVT, once I've made that diagnosis of SVT, and then I determine that they're stable, the first thing I try for SVT is vagal maneuvers, like have the patient bear down, pretend like they're having a really big bowel movement. If they're a baby, you can, I've heard that, I haven't done this myself, but I've heard that you can like, or I haven't seen it. I haven't done this myself and I haven't seen it done, I should say. Um, but I've heard that like if they're a baby and they have SVT, then you can like dunk their head into ice or something like that. Don't take my word for it, but that's what I've heard. Um, anyway, if vagal maneuvers don't work, you try adenosine. And then if adenosine doesn't work, then you switch to pharmacotherapy. Well, adenosine is kind of pharmacotherapy, but you get medicine on board to manage the SVT. Those being procainamide, amiodarone, lidocaine, or sotalol, or at least these are the medicines that I've seen. Um, and so the mnemonic that I have for these medicines is these are your pals in management of SVT. And these will show up later. So it's not like one mnemonic for one thing. Um, if they're unstable, they get cardioversion. Uh, for someone who has AFib with or without RVR, um, again, determine if they're stable or unstable. If they're stable, they get beta blocker verapamiltazem. If they're unstable, they get cardioversion. We talked about this before, but just because someone is so based on my understanding, like if someone is in RVR, that doesn't like immediately mean that they get cardioversion. So that by itself doesn't indicate cardioversion. It's more about the stability versus the instability. Okay, so here's what I was talking about earlier. There's a different management for AFib with pre-excitation, like Wolf Parkinson White. If they're stable, you don't give beta blockers, verapamil or diltiazem. You give the PALS medicine, procainamide, amiodarone, lidocaine, sotalol. Um, I'll talk about this in a second, but I'm going to get to the rest of the management. If they're unstable, they get cardioversion. So the reason why we give different medications for AFib with pre-excitation um, is because beta blockers, verapamil or diltiazem, they slow conduction through the AV node. Um, so if you have AFib with pre-excitation, the problem is that this rhythm is bypassing the AV node. So if you block the AV node, you're basically permitting more conduction through the accessory pathway, which would make things worse. Um, so yeah, you don't, that's why you don't want to give beta blockers, verapamil or diltiazem. Okay. Management of VTAC, if they're stable, they get PALS. If they're unstable, they get cardioversion. So very similar to SVT. Um, if they have VTAC, but they're pulseless, they get defibrillation. That's like the first thing you do. Um, VFib gets defib. So that's like a silly way that I remember the management of VFib. Um, management of torsade de pointe. This is one of those cases where you want to like determine if there's a cause, and if there's a cause, then you want to stop it. The causes being like medications that can prolong the QT interval. So those include antiarrhythmics, antibiotics, antipsychotics, antidepressants, and diuretics, antiemetics. And then you manage the rhythm with IV magnesium. If they have stuff showing up on their EKG, but you don't feel a pulse, that's pulseless electrical activity, and they get CPR. They do not get defibrillation. There's, that this is like this is not a shockable rhythm. Um, if they have asystole, they also get CPR. They don't get defibrillation. Okay, so we're going to slow things down a bit, quite literally, because we're going to talk about bradyarrhythmias. Um, so in this EKG, again, we will actually, yeah, so we'll just look at we'll look at each EKG because these are like a little bit easier to um, compare to normal and determine what's going on. So this EKG is an example of first degree heart block. The features of which, like if you look at the rhythm strip, it's the hallmark characteristic is that there's a prolonged PR interval. So there's like that distance between the P wave and the QRS complex is consistently prolonged. And so that can cause bradycardia. The management of first degree heart block, it's usually pretty benign, and if anything, is like an incidental finding on an EKG. So typically nothing. Okay, so here's a different EKG right off the bat. Again, the first thing I look at is the rhythm strip. Um, it's not regular compared to the previous EKG. And so we'll look at the P waves and the relationship between the P waves and the QRS complexes. So like here's this one, and then like it gets a little bit longer, it gets a little bit longer, it gets a little bit longer, and then there's a P wave, but there's no QRS complex. And then the pattern resets. So it gets longer, 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 and then it stops. Or not stops, but there's no QRS complex. This is second degree heart block Mobitz 1, also known as Wanky-Bach. Um, this mnemonic helped me out. It's not mine, so I won't take credit for it, but longer, longer than a block, then you have a Wanky-Bach. And so you can see that on the EKG. Like the PR interval gets longer, 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 then there's a block, and that's a Wanky-Bach. The management of Wanky-Bach or Mobitz 1 is nothing if they're asymptomatic. If they are symptomatic, you try atropine first. And if that doesn't work, then you try transcutaneous pacing. And if that doesn't work, then you would want to start going down the road of putting a pacemaker in. Usually, like on shelf questions or UWorld or Step 2 or whatever, the farthest you'll get from management of heart block is like, or of Wanky-Bach is like, or any Bradyarrhythmia, with like one exception, is to the point where you like want to give them atropine, or if there's an underlying cause. But like this general uh, algorithm is has helped me. All right, so let's look at this EKG. Um, you might know where this is going based on the pattern that we've been following. We're just like going down the bradyarrhythmias. So at this point, you've taken a chance to look at the EKG. This is second degree heart block or Mobitz 2. So unlike in Wanky-Bach or Mobitz 1, where it was like the PR interval got longer and longer and longer, and then there was a heart block, in Mobitz 2, the PR interval stays the same for P waves that conduct to a QRS complex. Just sometimes there's a P wave that doesn't conduct to a QRS complex. And you can see that on the rhythm strip here. There's like, this one's fine, and this one's fine, and then this one just for whatever reason doesn't conduct. And then it conducts again, and then it conducts, and then it doesn't conduct. The management of Mobitz 2 is the same as Mobitz 1. Okay, so here's a different EKG. Right off the bat, you can tell it's slow, very slow. And this also gives me an opportunity to say, like, if you're looking at an EKG, like one of the things that people think about is like, oh, you want to calculate the heart rate by dividing the number of big boxes, or you divide 300 by the number of big boxes between QRS complexes or something like that. Like you can do that, but like 99% of the time on a question or a vignette, they'll give you the heart rate. So you don't have to calculate the heart rate based on the number of big boxes between QRS complexes, especially if it's an irregular rate, because then you have many different possibilities of like where, points to select. So you don't necessarily have to do that. Anyway, on this EKG, this is third degree heart block, or it could also be called complete heart block. So if you look at the rhythm strip, there's the first, so like the hallmark features of complete heart block is there's a regular atrial rate and what looks like a regular ventricular rate, but they are desynchronized from each other. So the communication, like the cardiac conduction system between the atria and the ventricles is disrupted. So there's no communication between the atria and the ventricles. And so that's why you have like a regular atrial rhythm and then a regular ventricular rhythm, but they're just desynchronized from each other. And you might be tempted to think like, oh, this might be, yeah, you might look at this EKG and be like, oh, this could be a Mobitz 1 because like, this QRS complex has like a short-ish PR interval, and then this one has a longer one. And then, this next one has a longer PR interval, and then it looks like, this one's even longer, and then this one doesn't conduct to anything. But if you look between QRS complexes, like if you look at this here, here's the QRS, and then here's a T wave, and then this here is actually a P wave. Um, and that doesn't conduct. And you don't see that like prolonged, like you don't see that intermittent drop of a beat in Wenckebach. Um, so you don't want that to distract you. Another high yield feature of complete heart block is this can present in fetuses as fetal bradycardia, or it could present as like in a newborn as newborn bradycardia. And so the cause or like the risk factor for fetal bradycardia, like this complete heart block in a newborn or in a fetus, is congenital lupus or neonatal lupus. And that's associated, like if mom has anti-SSA or anti-SSB antibodies. The management of complete heart block is they need a pacemaker. Like even if they're a baby, they get a pacemaker. Okay. So that concludes the content that I wanted to cover in this episode. Again, if you made it all the way to the end, thank you so much. I appreciate your time. And I would really appreciate any feedback you have for me on how I can make this better, and how I can, improve accessibility to you all. So yeah, please feel free to leave any feedback you have in the comments.